So there's a strategy to the way the talks were put together in terms of the topics, even in terms of the order. So this is the applied talk. So my hope for this talk is to get you to think about how you can apply exposomics in your research, but also to think about a different way of doing environmental health research, even if it's not exposomics, even if it's more traditional environmental health research. There are other ways and other questions that we can ask that I will argue that we're not actually asking now, and yet we should because they're very important questions. And so the talk is really about exposomics and precision medicine, and the subtitle is Everything That Rises Must Converge. That's for those of you who are literary fans. Flannery O'Connor is a Southern writer who wrote a series of short stories with that title. The book itself, or the short story, has nothing to do with exposomics, but I thought it does sort of take that exposomics and precision medicine are both rising simultaneously, and my hope is that they will converge. So the outline of the talk is how will we apply exposomics to understand health and disease? And the second question is actually going to be a little bit different when I get to it than what you're used to. And I guarantee you that almost nobody in this room, there might be a couple exceptions, are actually doing research in the way that I'm going to propose it be done. I'm not saying you're not studying disease, I'm just saying you're not studying it the way that I'm going to suggest it should be studied. Precision medicine is the future. Whether you believe in precision medicine or not, it's clearly where we're going. And I think if we're going to do precision medicine correctly, we have to incorporate exposomics into it. I think precision medicine right now is ignoring the environment. But I'm also going to argue that we're largely ignoring precision medicine, and maybe that's not a good strategy for us. So now is the time to converge. So what is precision medicine? So the NRC definition is it's a tailoring of medical treatment to patient characteristics. We're going to create susceptibility classifications through disease, its prognosis, or its response to treatment. We're going to individualize interventions, maximize benefit, reduce treatment failure, and reduce side effects. It sounds fantastic. It means understanding each patient's individual background and how background influences disease progression and treatment response. It operates in a setting where the probability of disease is 1 and prevention no longer matters. And that's a key distinction. Most of us are public health researchers in this room. We don't operate in that space. So what is exposomics? It's not just chemicals. My definition of exposomics is much broader. It's much closer to Christopher Wilde's definition, where it's all of the environment. It's our nutritional environment, it's our social environment, it does include our chemical environment, it's also our physical environment. It's a study of all the health relevant environment across the lifespan. And I think several people, Linda and David have talked about how you can't really measure everything right now. We don't really have to, and it's important to know what not to do. And for those of you who know who Iggy Pop is, it's really hard to find an Iggy Pop quote that you can actually say publicly. So I think that one actually fits. So precision medicine is largely practiced as pharmacogenomics. The idea is if we understand genetic variation to treatment of disease, we can target therapies to the most effective drugs, we can improve efficacy and decrease toxicity, and we can even target some behavioral interventions if we know that if somebody has a particular genetic variant, maybe they should avoid certain types of food or activities. So we can improve counseling and decision making, and we can improve outcomes and satisfaction. But if all we measure is the genome, it only works if genes are the only source of variation in treatment and prognosis. And if you look at precision medicine websites across different institutions, really around the world, not just around the country, one thing that they all have in common is they all talk about genes, and they'll have a little schematic of a gene, and they'll all have about drugs and how they're going to target the drugs to the genes that a particular person has. But we know that genetics is only one piece of a much bigger puzzle. And for most programs, there's no mention of environment. This is another one. Again, you have the symbol of DNA, and you have the symbol of drugs, and how it's going to stratify people into different treatment categories. And here's another one. Instead of doing it horizontally, they basically did it vertically. But it's really the same concept. And again, no mention of environment. But we know environment's important, and we've known it for a really long time. In fact, this is the cover of Science in 2002. And the title of the issue is The Puzzle of Complex Diseases, and the introductory commentary was actually entitled, "It's Not Just the Genes." And in fact, there are articles in this issue about behavior, nutrition, infections, chemicals, physical environment, culture, society, and stress, all being important for complex diseases. And complex diseases are those non-communicable diseases that are driving healthcare costs in developed countries. It's autism, it's asthma, it's COPD, it's Alzheimer's disease, it's a whole host of diseases that affect every organ system and are the major drivers of healthcare costs. So how did we get here? So I grew up in the 70s and 80s, so you're going to see a lot of punk rock references. So David Byrne is obviously the singer for the Talking Heads. So how did we get here? So the complex diseases that we're interested in, that I just mentioned, include ADHD, obesity, asthma. All of them are actually an etiology of genetic and environmental risk factors. We've known that for a really long time. They're also becoming more and more common. We can argue about autism, but for many of the other diseases, they're actually pretty well measured. They're getting more common. If they're getting more common over a 20-year time span, genes cannot explain that, at least not the increase, because genes don't operate on a time scale of 20 years. They operate on a time scale of multiple generations. So any increase in these diseases has to be environmental. But the environmental risk factors for these diseases are largely unknown. And the way we study complex diseases, we tend to parse out the genetic and the environmental risk factors. We talk about heritability. And I think this idea of nature versus nurture actually creates barriers. Heritability estimates claim a percentage of a disease is genetic and a percentage of a disease is environmental. But genes don't actually cause disease. They actually infer risk. Just like environment doesn't really cause a disease, it actually infers risk. And the levels of risk for each vary. So when we take a step back and think about why do we even call diseases genetic or environmental? And I'm going to argue that if the genetic part of a disease, and all diseases are gene-environment interactions, but if that disease is caused by interactions between our genes and our environment, and the genetic polymorphism is low in prevalence and the environmental factor is high in prevalence in a population, that disease will appear to be genetic. And if the converse is true, the environmental factor is very uncommon, it's low in prevalence, and the genetic polymorphism is very common, we're going to call that disease environmental because that's the perception. This is hard to show in humans, but it's actually easy to show in chickens. So this is actually an example that Ken Rothman once gave at a lecture I saw. There really is a trait called yellow shanks that chickens get. It's a discoloration of their legs with a particular, if they have a particular genetic variant and they eat yellow corn as opposed to white corn. So imagine two farmers, Farmer Jones and Farmer Smith. Farmer Jones has an inbred chicken flock. All of his chickens carry the variant for yellow shanks. His family feeds them white corn because yellow shanks reduces the price at market. For generations they've been doing that. One day the store runs out. They have to buy yellow corn, otherwise the chickens will starve. All of the chickens get yellow shanks. If you ask Farmer Jones what causes yellow shanks, he will tell you it's an environmental disease because it's caused by yellow corn, because that's his perception. On the other hand, down the road you have Farmer Smith. He also has an inbred chicken flock. None of them carry the variant for yellow shanks. They feed yellow corn all the time because it's cheaper to their chickens. And then one day, one of the chickens gets yellow shanks. And then he's an amateur geneticist, and he starts plotting out the pedigree of that chicken's family. And it turns out he notices that half of his offspring get yellow shanks and the half that don't. None of their offspring get yellow shanks, and the half that do, half of them get it. And his pedigree starts to realize it's following an autosomal dominant inheritance pattern. From a biological perspective, what's happening in Farmer Jones's flock and Farmer Smith's flock is identical. But the perception in one is that it's purely environmental, and the perception in the other is that it's purely genetic. So which is it? Is yellow shanks environmental or is it genetic? And if we think similar things are happening in humans, and I guarantee you they are, is cancer really an environmental disease or a genetic disease? Or is it a mix of our genes and our environment? And even diseases that we think of as being purely genetic always have an environmental component. Sometimes you can't avoid that environmental component, and sometimes you can. Phenylketonuria is actually an example of an environmental component of a genetic disease that you can avoid, and you can actually modify the phenotype by changing the diet at a particular life stage. But in this context, what really is the heritability of chicken shanks? Is it 100%, which it is in one case, or 0%, which it is in the other case? And maybe the problem is heritability estimates aren't particularly useful because they're always going to be contextual. They're going to be dependent on the relative mix of the environmental and the genetic trait in a population that you study, because all genes operate in variable environmental backgrounds. And there's lots of backgrounds that genes operate in. There's a nutritional background. The way you metabolize a chemical or a drug varies based on obesity and its fat solubility. Whether you have a vitamin or mineral deficiency can also affect drug metabolism. Pregnancy clearly affects metabolism of chemicals, as does geography. If you live at very high altitude, you will tend to have a higher hemoglobin. If you have a higher hemoglobin, you have more red blood cells in your bloodstream. If you have more red blood cells in your bloodstream, there's a slight increase in viscosity. And there's actually studies that show that people who live at very high altitudes have higher risk of stroke. And it's probably because they have higher hemoglobins. Culture affects our life all the time. It affects social networks, it affects our health, it affects the foods we eat. Mixtures of chemicals also are backgrounds at which environmental factors occur, and genetics work, as is health. In fact, health, I'm going to argue, is actually one of the things that we're actually ignoring in public health, ironically. And I'll show you how we're doing this in a little bit. So disease changes the way we metabolize chemicals and the way we metabolize drugs. It increases the exposure to multiple drugs, the polypharmacy that Linda talked about. Health is really the focus of this talk. So, going back to what precision medicine is, this is a classic precision medicine example. A 53-year-old develops a deep venous thrombosis, which is basically a blood clot in their thigh on a trans-Pacific flight. Because they were immobile for about 12 hours, that immobility actually led to a DVT. So they get started on warfarin, which is a blood thinner. And she gets a GI bleed. So this happened because she carries a genetic variant that actually changes the metabolism of warfarin. She's a slow metabolism. If they had done a genomic scan, they would have realized that, and she would have got a lower dose of warfarin, and this would never have happened. That's a great example of how precision medicine with genomics could actually work. How about this example? A 17-year-old with autism has a notable increase in head banging and anger outbursts. This is actually a patient I once took care of. If we did a genomic scan, we would not find any genetic variant that could explain this. And plus, this is a change in behavior. So even though he's had autism his whole life, he's only recently had this change in behavior. So something happened in his environment. It turned out he was lead poisoned. So one thing that's a little bit unusual about this is you don't typically see 17-year-olds with lead poisoning. So I used to work in a lead clinic, and typically 2-year-olds get lead poisoned. 17-year-olds never do. In fact, he had a 3-year-old brother who did not have lead poisoning. The difference was he had autism. He had pica. He was eating non-food substances. He was eating newspaper. Newspaper ink has lead in it. This was obviously the 1990s because nobody has a newspaper anymore in their house. But in the 1990s, it was a problem for him. So we actually removed the source. We figured out that it was actually the newspaper and the ink. And we actually treated him because 73 is really, really high. He got chelated, and his symptoms resolved. So this is an example of a precision medicine approach which genomics would not have worked. And what about this example? So a 14-year-old has GE reflux, and he has a history of depression, and he breaks his leg. And so he goes to an emergency room, and he gets morphine for a fracture, and he starts to have respiratory failure. A genomic scan did not reveal any genotypic variation that could have explained a change in his morphine metabolism. So what happened? So I told you that he had GE reflux, so he was buying over-the-counter Tagamet, which inhibits the P450 system, and I also told you that he has a history of depression, so he was on Paxil, which also inhibits the P450 system, and maybe he liked grapefruit juice. He had a whole bunch of things that were inhibiting his P450 enzymes, and that's why he metabolized morphine differently. If he had had a genomic scan, we wouldn't have picked it up, but maybe if he had an untargeted chemical screen, it could have been detected. So this is a way that environment and exposomics might be able to play a role in precision medicine. So what is the most important background in precision medicine? There's all kinds of different backgrounds besides our genetic background. I'm actually going to argue it's not the genes or the environment, it's that third piece that we think about when we do research. It's the health outcome. The disease and the treatment actually are the most important backgrounds in precision medicine. And in environmental health, we never think of them. But we need to do studies that physicians need in order to treat patients. And I think that's a big gap actually in environmental health and exposomic research. And right now, we're really not doing that. So I'm a physician, I'm a pediatrician, and actually I used to be a pediatric ER physician. It bothers me that I always have to say I used to be. I haven't seen a patient in about 10 years. But from my perspective, when I practice medicine, I do environmental chemical exposure and neurodevelopment in children. I never invoked any of my research in a single patient I ever took care of in the pediatric ER, ever. And I kind of accepted that. And I sometimes wondered about it, but I didn't give it a lot of deep thought. So I recently decided to give it some deep thought, and that's actually where this talk evolved. So from a medical perspective, I want to know, how do I diagnose a patient? Exposomics and traditional epidemiology might actually help in that regard because risk factors are a kind of weighted variable. So I'm 56 years old. Maybe if I've been smoking for 20 years and I eat a lot of red meat and I come in with chest pain and I'm 56, I'm probably having a heart attack. So epidemiology can help in that diagnosis. But if I want to treat a patient, it really doesn't help very much because whether I get a stent, a coronary artery stent, or whether I get surgery is irrelevant to my diet and irrelevant to my past history of smoking. It's not going to change what I do next. And that's the perspective of a physician. He or she wants to know, a patient's here, a patient is sick, I've diagnosed the patient, what do I do next? The fact that they smoked really doesn't matter anymore. And the fact that they might have been exposed to chemicals when they were a child actually doesn't matter anymore from a medical perspective. And in fact, physicians largely ignore environmental health research, I would argue, particularly for this reason, because it doesn't affect the way they treat patients. Smoking does not impact the treatment for heart disease. It might cause heart disease, but it doesn't impact the treatment. So there are no right answers to wrong questions, in other words. So I would actually argue that from a precision medicine perspective, exposomics right now is not asking the right questions. So what are the roadblocks? So in medicine, we deal with the individual who's in front of us. We want to know the diagnosis. We know there's a problem. They came to our office, they came to the emergency room, there's something wrong. People don't do that randomly, so there's definitely something wrong. We may not know what it is, but we know there's something wrong. And then we want to treat whatever that problem is. And we want to reduce the side effects. We want to get the best outcome possible. Public health is very, very different. And most of us do public health research. I do public health research. We don't deal with individuals. We deal with populations. We think about risk factors. If you're exposed, will you get sick down the line? Not, are you sick today? Will you get sick down the line? It's a very different dynamic. So we're talking about probability of an illness. In medicine, we know there's something wrong. There's certainty that there was an illness. So it's a very, very different perspective. Public health deals with prevention. I definitely believe in prevention. I'm just pointing out that it's a very different perspective than medicine and treatment. And we think about susceptible populations, pregnancy, people who are pregnant are a susceptible population, children are a susceptible population, the elderly are a susceptible population, but we're not talking about whether they're sick now, we're talking about preventing them from getting sick in the future. So medicine starts after a person is sick and public health starts before a person is sick. Again, a very important distinction because outside of primary care, medicine isn't really interested in why you got sick. They're interested in how to treat you at that moment. And right now, if we want to be involved in precision medicine, we should do research, or we should be doing research that actually addresses that question. And there's a lot of research that can be done that really needs to be done and hasn't yet. So again, this is a summary of the differences between public health research and medical research. So in public health, we start before the person got sick, and in medicine, we start after the person got sick. So the x-axis is time. So in public health, we might do a prospective cohort study, or we might do a case control study where we're trying to go back in time to see what were the risk factors that caused the disease. We start when the disease is not present, or we try to infer when the disease is not present if we're doing a case. I don't know why I'm doing that. Why are we doing it if we're trying to do a case control study? So if we're doing a clinical observational study, if we're interested in medical outcomes and medical treatments, we start with people who are sick, and we go forward in time. And we can measure their environment, and we might actually understand why somebody doesn't respond to a treatment if we were to measure their environment. So if you have diabetes and you use a lot of perfume and you're exposed to a lot of phthalates, and we believe phthalates are endocrine disruptors, I'm not necessarily saying that the phthalates caused your diabetes, but I'm wondering if the phthalates that you're exposed to after you develop diabetes is affecting your dose of insulin. And that's an important question for a physician. And it's something he or she can do something about. And yet we're not doing research in that space. But that's a precision medicine question, and that's very, very different than what we're currently doing. So instead of only studying causation and risk factors, maybe we can study the effect of environment on diagnosis and treatment. And that's really where precision medicine and exposomics can converge. Most precision medicine studies are going to start after the disease onset, not before, and should move forward in time and look at disease progression. So again, medicine versus public health. So in public health, in summary, causation is our goal. We want to understand why a disease happened. Because diseases aren't uniform, there isn't a type of Parkinson's or a type of autism or a type of Alzheimer's disease. They're all multiple phenotypes that actually have very similar characteristics, and they may have different causes. It's actually kind of hard to understand how environment or even genes cause a disease. On the other hand, maybe every one of those subphenotypes reacts the same if someone gets exposed to lead, which is neurotoxic. It doesn't matter which subtype of Alzheimer's disease you have. Maybe you're going to have a bad reaction to lead, and maybe we can do something about your lead exposure that's actually going to make you feel better. We're not going to cure your Alzheimer's disease, but maybe we can actually improve your outcome and your long-term trajectory. So maybe these non-specific phenotypes of different complex diseases don't matter as much. Linda talked about time travel in public health. If you want to understand what causes a disease, you have to understand the exposures that predated that disease. That's a difficult thing to do. Manish Arora has done a lot of work in that area, and there are some things we can do if we want to understand the cause of a disease. But maybe the cause of a disease isn't all that important for the treatment of the disease. So time travel actually may not be necessary if we're going to study precision medicine. We just need a group of people who have a disease, measure their environment, and then follow them longitudinally to see whether or not if you have a particular exposure, you're more likely to have a complication or you're more likely to not respond to a traditional treatment. And that's something we can do right now without having to do time travel. And instead of counseling at the population level, and any physician will tell you this, telling a person they really shouldn't smoke who doesn't have heart disease or lung cancer doesn't work, or it works very poorly. On the other hand, my father smoked for 30 years. He had four-vessel bypass and a massive heart attack when he was 49 years old. He quit smoking the next day. Of course, he was on a ventilator for a few days. But he quit smoking even after he recovered. And so people who are sick, they listen, because it means more to them. So it's actually easier to counsel people who are sick. Healthy people are also harder to recruit. Anybody who does an observational epi study will tell you that, particularly in children's health, because families are really busy. You know, I remember when my kids were young, my weekends were more stressful than my weekdays because I was running from event to event to event. It's hard to commit to a study. People who are sick want to know why they got sick, and they want to know if there's something you can do to make them better. They're much more likely to say yes, and they're much more likely to stay in the study. So I'm actually going to argue that it's easier to do these kinds of research. And also, because you're looking at causation, you often need a control group. At least you do if you're doing a case control study. I don't think you need a control group if you just want to understand whether or not lead exposure actually affects Alzheimer's disease or autism. Not the cause, but the severity of the phenotype. In that case, all you need to do is recruit people with the disease, measure their exposure, and follow them longitudinally. So precision exposomics. Why should we be doing this now? Well, there's been exponential advances made in exposure science in the last 10 years, and you're going to hear about all of them. at this Symposium in the next 2 days. Every one of these examples on this slide, there is a talk dedicated to it. So you're going to learn a lot about what can be done. And I think for those of you who aren't in the field, you're going to be surprised about how much can be done, because a lot has happened in the last 10 years. So public health research has typically focused on vulnerable populations, and I think that's very laudable. But largely, we've ignored probably the largest vulnerable population, and that is people with a disease. People who are sick are likely to be very vulnerable to their environments, and we rarely study how they're vulnerable to their environments because we're very, very focused on understanding how people get a disease. We're less focused on how they respond to treatment, and we're less focused on whether or not their progression of their disease is actually affected by their concurrent environment. And I think that's a space that we should be living in, because that's a precision medicine question. And we're going to help a lot of people if we do this, because these people are already sick. And there is stuff that can be done that falls within the environmental health range. And I think that's something we really have to think about doing. And they are a vulnerable population. They're probably the largest vulnerable population in developed countries. You look at the rates of disease, particularly obesity, they're growing. So this is a big chunk of the population. It's not a small number. So how can we operationalize this? Well, maybe we should be running untargeted assays in cohorts of people who have cohorts of patients longitudinally. That way, maybe we can predict risk of complications during the treatment. If we have pre-complication effects in people who are sick, they come in, they see the patient, or see the doctor, it's actually a little easier to get their samples. Maybe we can predict whether there's a signature in the untargeted assay that actually can predict who's not going to respond to a treatment or who has a complication. And we could even potentially tap into existing cohorts that have samples already, so we can actually do this relatively rapidly. And study designs matters when we're applying exposomic data. We really want to look just at the cases, is my argument. There's also a lot that can be done with wearable devices. I'll bet everybody in this room has a cell phone. A cell phone is a wearable device. Your cell phone probably tells you how many steps you took today. Your cell phone may also tell you where you are. I'm sure Google knows where you all are right now. And Google probably even knows that you're indoors right now. Well, if we have satellite remote sensing maps of temperature and air pollution, and we have a cell phone that tells us where we are at every moment, we can really do detailed measurements of our temperature and our air pollution exposure by traveling through those different maps, if we have those. And there are even exposome-related wearable devices. So Heather Stapleton does a lot of work with the My Exposome bracelet. That is a wearable device that can tell you what exposures are in your external environment. So there's a lot of work that can be done. And we don't necessarily have to just do it in healthy people. Why don't we do it in patients? So why don't we do disease cohorts where we actually look at exposure to air pollution, exposure to temperature, wear these exposome devices, and also track their activity. Maybe if someone's getting chemotherapy, we can actually get a sense of how sick they are based on how active they are. We can really get granular data on how active they are if they're wearing a wearable device. Maybe if they're having a particularly strong complication to their chemotherapy, maybe there's some information in the My Exposome bracelet that could tell us why that happened, or in an untargeted assay that could tell us why that happened. This is a space I think we need to live in. We could even look at things like heart rate variability and air pollution after you've had coronary artery bypass surgery. Maybe you're more likely to have a second heart attack, and we can actually predict that with some of these wearable devices, or even untargeted assays or targeted assays if we know that they're cardiac toxic chemicals. There's a lot that can be done in the GIS world. We can measure temperature, we can measure green space, we can measure air pollution, traffic, noise, access to healthy foods. Itai Klug, who's going to talk, I believe, tomorrow, actually has done some work in the social media world where he's actually, this is actually a geospatial paper where he looked at the geospatial distribution of mean tweets. I know there's probably a lot of political jokes embedded in that, but he looked at the mean tweets in the state of Massachusetts and he plotted their geospatial distribution, which I think is something that can be done. I think social media is a largely untapped environmental factor that actually has a lot of information in it. So further operationalizing this. So it's like, grew up in the 70s and 80s, so I like punk rock. If DDT did a job on you, and it probably did to Joey Ramone, although people would argue that DD got it worse. Wearable devices might be something that you bring to the doctor's office one day. And you might actually take your cell phone, give it to your doctor, they'll download all the information, and they'll have information on your air pollution exposure since your last visit, as well as your physiologic activity. They can get your address history, and they can figure out what kind of exposures you have to crime or healthy foods based on your address history or your occupational history. Download all this into your EMR, and then they can do some EMR searches. Maybe they can get a urine sample or a plasma sample and do an untargeted assay screen. And then maybe because they'll have your genome screen on file, they can look at genome by exposome interactions and predict risk scores for your health, or predict risk scores if they want to start you on a new medication. That will actually tell you whether or not it's going to work, or if they want to add a medication, whether or not you're likely to have a drug-drug interaction because you're starting to develop a polypharmacy that's more dangerous. So, Neutral Milk Hotel, I wake and see the streets are ice cream. So in the future, this may actually be a way that exposomics will be incorporated into healthcare and precision medicine. So this is such a wide open space that it's very easy to come up with ideas, particularly if you're in the environmental health world and you know what the relationships are in the literature between environmental exposures and health effects. So these are just some gratuitous examples. I could probably make 3 or 4 slides. Maybe phthalate exposure in patients with cystic fibrosis may actually increase their risk of diabetes, since patients with cystic fibrosis are at higher risk of diabetes. Maybe environmental obesogens may modify the amount of insulin you need if you have diabetes. Maybe there are neurotoxic metals, such as lead or mercury or arsenic, that are modifying patients who have Alzheimer's disease or Parkinson's disease, their severity and their progression. Again, none of these examples, I'm arguing that these exposures cause the disease. I'm arguing that we should be studying how they're affecting the disease, which is a slight distinction. Maybe we should be looking at air quality in surgical ICUs. Maybe if a particular ICU has a poor outcome, maybe they actually have a lot of particulate matter in the air. Untargeted chemical assays might be useful to diagnose eating disorders, such as anorexia or bulimia, in a screening in a primary care physician's office. There's a lot that can be done. And unlike causation research, the field is so open that most of these are really low-hanging fruit. So in the future, I think exposomics and PMI is going to enable diagnostic tests so that we can identify subpopulations that may have different health outcomes. We're going to understand the relationship between the patient's chemical, nutritional, physical, and social environment and their prognosis of their disease. And we're going to identify optimal treatment based on their exposome. We can predict their response variability to exposure, their side effects better, and their compliance better. So that precision medicine programs are going to look more like this, where it's not just genetics that's stratifying whether or not you get a particular treatment, it's all the environmental factors that you also live in. And that's the last slide.